So I want to thank Francisco for this opportunity to chat with you all about the work that we've been doing about EEG monitoring. And, excuse me, and you know, it's a great opportunity to be here and to share these ideas with you. And I'm going to talk about the work that we've been doing roughly about the last 12 years or so to try to get our heads around what happens under anesthesia. I mean, for me, one of the big things is there's a lot of discussion about mechanisms, but the question is, how does the mechanism relate to what you see in the operating room? And then how does that tell you to do anything different? And so that's what I want to try to connect. And I want to make a very, very simple point here. The EEG is like highly informative, and it's a very, very strong signal whose value has been underappreciated. It contains a tremendous amount of information that we're not using, and it gives us insights not only into how the drugs are working, but it gives us insights into sort of fundamental ways in which the brain is structured. And that's one thing I want to give you a sense of here. So these are the folks that I've had the good fortune to work with over the last few years. Nancy Capel, who's a mathematician at Boston University. My colleague Patrick Purdon, who's a neuroscientist, bioengineer at MGH. And Ahmad Eskandar, who's a neurosurgeon, who's at MGH and now is at Einstein. Sid Cash, who's at Mass General. Laura Lewis, who's at Boston University. Laura Cornelison at Children's Hospital in Boston. Seung-Yoon Kim is one of my postdocs who's now back in Korea. And Siuna Keiju, who is at Mass General also. And what I'm going to do is I'm just going to turn this on just so I keep time here. So I'm just going to make three points here. The first is I'm going to show you that all anesthetics actually produce slow delta oscillations. And this is in keeping with something that I've called Bearnaise principle. And you'll see what that is in just a second. The differences in EEG patterns actually reflect differences in the neurophysiology of how the drugs are acting in the brain at specific receptors and neural circuits. And with those, you can understand the mechanisms through which they're acting. And I'm going to show you that the EEG power changes very systematically with age, and it reflects sort of normal brain development as well as the aging processes. All right, so a definition of anesthesia. So a drug-induced state, which is reversible, in which we produce antinociception or analgesia. And I call it antinociception because if you're unconscious, you can't really perceive pain. Antinociception means that you're actually turning off the nociceptive system, or at least impairing information communication there. Unconsciousness, amnesia, akinesia, and stability and control of the physiologic systems. Now, we often say that it's not clear how anesthetics work, and I want to give you some sense of that the reason we don't perceive as much information about how the drugs are working is that we really haven't paid attention to the neurophysiology of what's happening when patients are anesthetized. And that's what I want to give you a sense of here. So I'm going to talk first about what I call anesthesia-induced slow oscillations and Bearnaise principle. All right, so here's the idea from Bearnaise. It goes back to 1935. Bearnaise was a Belgian neurophysiologist, and what he did was a series of 2 experiments. In the first experiment, what he did was, this is in cats. I mean, I've drawn this here on the human brain, but what he was doing was in cats. And in the first set of experiments, he transected the spinal cord here, so separating the brainstem and the brain from the spinal cord, okay, at this level here. And he called that encéphale isolé. So he's isolating the encephalon, all right? Now, when he did that, what he found was the EEG had this pattern that looked awake, all right? Then he did a second set of experiments in another set of cats in which he transected the spinal cord here. Now, this is the brainstem is intact with the spinal cord, and he's separating the brain from the brainstem and the spinal cord. And he called that the cerveau isolé. Not cerveau in the sense of whole brain, but cerebrum in French, all right? So this he called the cerveau isolé. And what he saw was these large slow oscillations. And then this is one of the first set of studies that gave us insights into the fact that in the brainstem there is where the arousal centers are sitting, what we often call the ascending arousal circuits. But one of the main things for this discussion that happened is what you see is any time you take away inputs coming from this part of the brain going to thalamus or cortex, you generate slow oscillations. Or anytime you impair activity substantially in the thalamus and cortex, you generate slow oscillation. I'm just going to show you that because all the anesthetics do it. All right? So this is just to make a statement of this. So blockade of brainstem inputs from the thalamus and the cortex leads to production of slow delta oscillations by reducing excitatory inputs to the thalamus and cortex and thereby producing hyperpolarization of the cortex. Now this is, I mean, Bearnaise didn't say all this back in 1935, but this is putting it in today's context and thinking a little bit about what's known about how slow oscillations are generated and sort of neurophysiology there, all right? But before we go any deeper to this, now I just want to go to the OR for a second, all right? So this is a video I like to use because it illustrates just how powerful the anesthetic effects are. So this is a lady I took care of. It's been about 5 years now. And she's going to have thyroid surgery, and we're going to give her a bolus of Propofol. And we're just going to watch the EEG changes that transpire as she becomes unconscious, all right? And I'm just going to talk you through this, all right? So we inject the Propofol, and those are eye blinks if you haven't really paid attention to this on the EEG before. And these are 4 leads of EEG, so there are 2 leads here, 2 on the left, 2 on the right, and then the ground and the reference are in the center, all right? And this is going to get noisy here in a second, real noisy. And that's because, as you know, when you inject Propofol, it burns like crazy when it goes in. So she's tensing up now. So that's actually going to be good from a pedagogical standpoint because you're going to see exactly when the drugs take effect, right? So just about another 6 or 8 seconds here. Watch right here. So right now, boom. See those beta oscillations starting? Now, large, slow oscillations, all right? Even bigger. And now watch what happens. Burst suppression, all right? So very deep, very quickly, all right? So let's just go back and look at this now. All right, in the context of Bearnaise principle, and let's go back and look at the anatomy here. All right, so first of all, the thing that's relevant is how is the blood getting to the brainstem? So this is, if you take the brain and turn it over, here's the circle of Willis. And the basilar artery runs right here along the underside of the brainstem. All right, it's made from the fusion of the 2 vertebral arteries. All right? So it's running like right along here. All right? And now, these are where those arousal centers were sitting. So this is this area that Bearnaise isolated when he did his studies. All right, now, so just some very basic things. One of the first things you see when someone becomes unconscious under anesthesia is that you see they stop breathing. Okay, so dorsal respiratory group, ventral respiratory group. They're made up of excitatory neurons, which are mostly glutamatergic, and they're made up of inhibitory neurons, which are GABAergic. And this system is doing this. That's how you breathe. So if you give Propofol, and it comes through the basilar artery here, hits these centers here, you're going to stop breathing. That's going to produce your apnea. Makes sense. I mean, this isn't deep. I mean, we're just going to go through the basics, but because these are the things that we should be using in the operating room when we're taking care of patients, all right? And we should stop saying we don't understand how anesthetics work, all right? If you move a little further up, here are the arousal centers, all right? Now, and I've color-coded them on purpose. So see the guys in the middle, I've colored them blue, and the guy in the front and the back here, I've colored them green. So these guys here in the front and the back are cholinergic centers. Just like in the periphery, you have the parasympathetic and sympathetic systems. There's a similar organization here, in that they're cholinergic centers here in the front and cholinergic centers here in the back. And through the middle here, you have these monoaminergic systems. So this is the locus ceruleus producing norepinephrine, dorsal raphe producing serotonin, tuberomammary nucleus producing histamine, and the ventral paraequital gray, which produces dopamine. So it's 2.5. The one which is the oddball is the orexin center. Now, here's the relevant anatomy. This is the key point. Starting right here from the preoptic area of the hypothalamus, right? From right there, if that area is my wrist, like this, all right? Then that preoptic area sends inhibitory projections from here onto each one of these nuclei. Those inhibitory projections are GABAergic, all right? So when Propofol comes along here and hits those circuits, What did you see in the video? Large, slow oscillations. Bearnaise principle, urine activating the brainstem. You saw it get taken out. That's what's happening. That's part of what's happening. It's not the whole story, but I just want you to understand the brainstem part because it lines up perfectly with the clinical picture and it lines up perfectly with the anatomy. At the same time, the drug is not just getting here, but it's getting to these other sites. And in fact, the effect was probably first seen in the cortex because that's where those beta oscillations were generated. And we can show you why that's the case mathematically, but just accept that little factoid for the moment. All right? And so that gives you just a lot of insight right there into why you would produce unconsciousness very rapidly with propofol. Again, these arousal centers have GABAergic inputs coming to them. You have GABAergic inputs sitting here around the thalamus. So the thalamus is like this, and there's an entire GABAergic net sitting around it, which is the thalamic reticular nucleus. And then sitting here in the cortex, which isn't shown here, are all these inhibitory interneurons, perfect GABAergic sites. So thinking that the drug is causing unconsciousness by acting in some site, isolated, really doesn't make sense. It's acting in all these sites simultaneously, and I think that's the way we have to think about it. All right? There's more that I could say about the atonia, but I'll skip that for the moment. So these are the states that we saw this lady go through. She was awake. Then she went to the sedative state here, which was the beta oscillations. Then we saw her jump way down to here to these large, slow oscillations. She was in burst suppression. The period between the bursts, she's isoelectric. Another key point here. The EEG under anesthesia is the strongest EEG signal there is. It has the highest signal-to-noise ratio for anything that the EEG is used, whether it's looking at sleep, whether it's looking at coma, whether it's, for example, doing cognitive studies in patients. And you saw why here. Look, pretty much for anything else you use the EEG for, there's movement. So the movement artifact already colors the problem. But the other thing is that, and what I'm going to give you a sense of here now, is that the drugs are taking over the circuits and they're driving them in unison. So you get amplification in these very, very large oscillations. I mean, look what happened. You go from this when you're awake, which is 5 microvolts, down to this when you're anesthetized, which is somewhere between 20 to 50 microvolts in amplitude, peak to peak. All right? So to do that, you have to get large parts of the circuits acting in unison. Right? And that's exactly what is transpiring. Right? So the fact that we don't use the EEG, in other words, we have the strongest EEG signal and we don't use it, I mean, we're wasting information. We're wasting an opportunity to take better care of the patients, but also to learn more about the brain. And now, in the spirit of saying that all drugs produce slow oscillations, let me just start this with propofol. So for me, this is one of the most compelling bits of work that we've done that gives insights into how the drugs are actually working. So this is from studies that we've looked at in patients who are having epilepsy surgery. So when a patient comes for epilepsy surgery, they get electrodes implanted. They stay in the hospital for a series of days. They seize. Once they figure out where the epileptic focus is, they come back in, they take out the electrodes, and then they do the resection. So when they come back to the operating room the second time, you have a human patient that has electrodes in the brain, so you can just give propofol and record and actually see the dynamics of human neurons when someone becomes unconscious. Now, if we accept the idea that one of the basic ways in which the brain communicates is by neural activity, then understanding how the drugs may be producing unconsciousness can be reduced to some extent to look at the question of how do the drugs affect the ability of the parts of the brain to generate neural activity, spiking activity in particular. All right? So let's just look at this. So here's an observation. So this is from Laura Lewis's PhD thesis. She published it in PNS back in 2012. So this is the EEG when the person's awake. The local field potential is being recorded at these sites on the brain. And then here's the spiking activity. So it's just, pretty broadband, no particular organization. Look what happens when the slow oscillations start and the patient is unconscious. All right, so there are two key features to this I just want to point out. When the slow oscillations start, this is a neuron that's recorded next to this red electrode. It can now, instead of being able to spike wherever it wants to, it can only spike like this now. And these are about 2 to 4 seconds, just like that. All right? So This neuron here sitting next to this electrode can only spike at this phase. This neuron sitting around next to this electrode can only spike at this phase. So what you have is this fragmenting of the cortex. So the neurons here can only spike here, the neurons there can only spike there. So it's going to be very, very difficult to communicate. And this is going on all across the entire cortex. And this is specific for propofol and the GABAergic drugs. With dexmedetomidine, it's actually different. It's not the same structure. All right? So if you have to spike and be able to transmit information between sites that are pretty close to each other in order to be conscious, you can see very, very well why you'd be unconscious under propofol. And again, propofol is producing the slow oscillations. And so this is the way it looks in the operating room. You would see the slow oscillations here, and you'd see the alpha oscillations. I haven't talked about the alpha oscillation. I'll come back to that. But here's what I was saying. Here's that anatomy. So you see right here, here's those projections coming from the preoptic area onto these brain centers here, the arousal centers. There's the thalamus. There's the GABAergic circuit sitting around it. And then here's the cortical interneurons. Remember, in the cortex, what you have is you have about one cortical interneuron for about every 10 pyramidal neurons. So they act as routers. So if you get control of the cortical interneurons, you're going to be controlling a large part of what the cortex is able to do. So again, the drugs, in other words, propofol goes everywhere. It's very lipid soluble. We know that. Sevoflurane, the ethers go everywhere. So they're hitting all of these circuits at the same time. All right? So just to take another example, dexmedetomidine. All right? So dexmedetomidine actually works by blocking presynaptic release of norepinephrine. All right, so we say that. So then what we should do is draw the circuit. If that's the case, then we can draw the circuit to see what happens. So here's what it looks like. It's very similar. It starts with some of the same anatomy. So there's the locus coeruleus sitting there, and it has four main projections. It goes to the preoptic area of the hypothalamus. It goes directly into central thalamus. It goes to the basal forebrain. And it goes to the cortex. All right. So it's like this. It's just like there are four main projections. They're going up like this. They're excitatory projections. You take away those excitatory projections, Bearnaise principle says you should get slow oscillations. And that's exactly what happens. This is a low dose of dexmedetomidine here, where you get the slow oscillations as well as the spindles. Once you push to a higher dose, you actually get just slow oscillations entirely. Right? So the same idea. And now, this is actually my most favorite example. This is nitrous oxide. So I was doing a case a few years ago with one of the chief residents, and this is when I was really starting to really look in detail at the EEG patterns under anesthesia. And so she said, I'm going to switch over to nitrous oxide and wake the patient up for nitrous oxide. I said, oh, that's cool, because I said, I haven't seen the nitrous oxide patterns. So the patient was on sevoflurane, like here. So there's very intense alpha, theta oscillations, slow oscillations here. And you can see right here, she switched over to the nitrous oxide, turned up about 60, 70%, and then turned this is isoflurane here in this case, turned the isoflurane down. And about 3 or 4 minutes after that, all of a sudden, these huge oscillations came on the EEG. I mean, just like enormous. I mean, I'd never seen this before. I said, what did you do? And she said, I just turned on the nitrous oxide. And it was like amazing. It looked like a tsunami. And they're enormous. They look just like this. And you can see them here, right there. Then the thing that was interesting, they didn't last. They were there for about 6, 8 minutes, and then they disappeared. And you went to this sort of high-frequency oscillation pattern that you see over here, right? So, again, thinking in terms of Bearnaise principle, how could this be produced? Well, one of the ways in which we postulate that nitrous oxide works is blocking NMDA receptors. So if you go into the brainstem and you look for NMDA or glutamatergic circuits, there are two main ones. There's this one in the parabrachial nucleus, and there's this one in the medial-pontine reticular formation. And they have very, very strong projections. This one is worth knowing about. The parabrachial nucleus, it's like a glutamatergic superhighway. It's a very, 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 very strong connection. So when you stimulate that area, it just sends a major arousal signal. By the same token, if you take this area out, you're going to have a profound decrease in arousal. So this is what we postulate was happening here. But I couldn't tell you why it's transient. I can postulate why it would come about initially, but I can't tell you why it goes into high frequency terms. And just to show you just what this looks like on the EEG, I mean, I'd never seen this level of EEG or EEG structure like this in the operating room. And in fact, a few weeks ago, we were giving anesthesia to a woman who was a drug addict, and the Propofol started going in, and it was burning. So she does this with her arms. So the IV comes out, and only part of the Propofol had gotten in. And so my colleague says, okay, let's just do a mask induction. So she turned up the sevoflurane, and she turned up the nitrous at the same time. And so when she turned up the nitrous, it's like, whoa, these are cool slow oscillations. I said, excuse me, I know we have an emergency here, but I got to take a picture of this. So I was like, picture, okay, back to emergency. So she just produced these like right on the spot there. So I mean, it's a little mixture of things like the sevoflurane, but it's when she turned the nitrous on to 60% that these huge slow oscillations just popped right out. So there's something really, really interesting going on there. And then here, with ketamine, it's the same thing. At low doses of ketamine, you actually get high frequency oscillations. But once you push up to, if you do a ketamine induction, you'll see this really, really amazing pattern where you'll have high frequency, then low frequency. High frequency, then low frequency. And it looks just like this. It looks like a high frequency period there, a low frequency period, then a high frequency period again. They alternate. And they alternate in about 6 to 10 second intervals like this. All right? And again, you can go to Bearnaise principle. Like right here, there are these strong glutamatergic projections, the same ones where nitrous oxide would be working. We can postulate that these would be where the ketamine would be working in order to produce these large slow oscillations here. The high frequency oscillations are different. That's a whole different phenomenon. They occur at low dose ketamine. And the reason they occur at low dose ketamine is that it really depends upon the NMDA channel. So for ketamine to work, it has to actually get into the channel and block transmission. So if you look probabilistically, the inhibitory interneurons channels are opening and closing much more rapidly than those in the pyramidal neurons. So just at low dose, the probability that you're going to block the interneurons is going to be higher. So that's why initially you see blockade of the interneurons. You get an active EEG, right? And then once you give larger doses, you get the larger slow oscillations. And so this is the state here that's more associated with like the hallucinations because you're inhibiting inhibition, so you get an active EEG pattern, all right? And then I'm just going to throw in a couple of factoids, which we'll come back to at the end, because they fit in sort of conceptually right here. In young kids, very young kids, 0 to 3 months of age, all you see are slow oscillations when you anesthetize them. In older patients, you very frequently see just sort of slow oscillations, no alpha oscillations when you're using like your ethers or like Propofol. And then in patients who are like really, really sick, like when I get these patients who come down from the ICU that have had like particularly like overwhelming sepsis or this sort of thing, the EEG often shows just very, very large slow oscillations, right? So I just want to say a little bit more about sort of neural circuits. I talked about the slow oscillations for these drugs, but I just want to talk a little bit more about some of their other effects. And in particular, like with Propofol. So as Tony was talking about earlier, there's all this discussion about whether or not you have frontal parietal disconnection as one of the mechanisms for reducing anesthesia. And I think in our own literature, we have an explanation for that, which has been around for years, but I think we just haven't appreciated it. So this goes back to 1977. John Mitchenfelder and John Tinker at the Mayo Clinic did these studies in monkeys in which they gave them influrane. And one of the things that they noticed was that when they gave them influrane, they had whole head EEG on, and the oscillations, like the alpha oscillations, the 10 hertz oscillations, moved from the back of the head to the front. And they called this anteriorization. So we've done studies where we've done whole head EEG in patients, in volunteers. And this is the spectrogram taken on 44 of the 64 sites. So here's a person who's lying there like this, and I have to tell you one other thing. So if you close your eyes like this, and I put electrodes in the back of your head, right, you're going to get 10 hertz oscillations. They're called occipital alpha oscillations. Pretty much everybody has them. About 10% of the people don't. They might get a little weaker as we get older, but they're pretty reliable. You can just do this right here, and you'll get very, very strong 10 hertz alpha oscillations. And so we have this is a male subject. So he's lying there with his eyes closed, and you can see 0, 10, 20, 0, 0, 10, 20. So he's here like this with his eyes closed. So we're going to give him increasing doses of propofol, right? And as the propofol increases, this alpha oscillation is going to move from the back here to the front. It's going to concentrate in the front. And the one thing that I want you to appreciate is, in the front here, you're going to have alpha oscillations and slow oscillations. In the back here, you're going to have just slow oscillation. You're going to have a very distinct pattern between the front and back of the head, all right? And this dynamic here is probably what folks are seeing when they're pointing out frontal parietal disconnection. So let me just play this for you, just to show you. So, no drug yet. So now you start administering the drug. Now watch what happens. Watch how this is a controlled infusion, computer-controlled infusion, using the Snitter model, right? So you see how this disappears here. There it concentrates in the front. And back here, you just have slow oscillations in the back. And then when you get to level 5, that's the deepest level. Now, when you turn the propofol off and you let it, and the person recover, the slow oscillations move, the alpha oscillations move to the back again. All right, so it does this. All right. So we've spent a good amount of time thinking about where these slow oscillations, how they come about. And so it's not just sufficient to talk about drugs binding to receptors. You have to think about how the regions are connected. And so this is a little bit of that anatomy here. And then the other thing is you have to do a little bit of neurophysiology too. So if you record these alpha oscillations there and you look at them, remember I said the slow oscillations were disconnected across the region. What's ironic is that even though the slow oscillations are just as strong as the alpha oscillation, these guys here are totally disconnected. The alpha oscillations in the front of the head are totally connected. They're totally coherent. In fact, if you measure the correlation between two sites, one here, the correlation is about 0.8 or 0.9, right? So in thinking about how this might come about, with some help with some mathematical modeling and now experiments both in monkeys and in rats, we postulated this is an oscillation going back between the thalamus and the cortex. So this oscillation is tying up the thalamus and the cortex, making it very, very difficult for these parts of the brain to communicate. And I would submit to you, if you would tie up the thalamus this way, you're going to have something which is contributing to you being unconscious. So you've got two things. The cortex is fragmented, as evidenced by the slow oscillations, and you've got this thalamocortical oscillation, which is keeping essentially the cortex and the frontal cortex and the thalamus in this fetal cycle. So, and as I said, we know this now because we stuck electrodes here and here in rats and monkeys and verified that. So just going back to DEX for a second. I didn't say anything about the spindles here. So there's not just the slow oscillation, but at low doses you get the spindles. And sometimes people call these like alpha oscillations, but they're not alpha oscillations. They're much weaker. So if you look at those there, and you go back here to propofol, this is far stronger. Okay. All right. Thank you. This one here is much stronger. And what's transpiring here is as the dexmedetomidine acts and it progressively hyperpolarizes the cortex more and more, you break up the ability of the cortex to produce these spindles. There are the spindles there. And that's why you end up with just essentially the slow oscillations. And then I just wanted to show you a couple of combinations. So it's like, okay, if you're using pure drugs, okay, maybe that makes sense. But what happens if you use combinations? Well, the combinations make sense also. So here's ketamine. This is a gentleman I was taking care of who was having like a vacuum dressing change. So I had him on a ketamine infusion. And then I decided to give him and intermittently so this is working by blocking these inhibitory interneurons, so you have this high frequency oscillation at 30 hertz. Remember, this is 30 hertz. Propofol is down here at 10 hertz. So when you give him propofol boluses, and remember, the ketamine is acting here by inhibiting this inhibitory interneuron, so it's making this more active. So when you give propofol, here's what's happening. Here's an inhibitory interneuron. It's being inhibited by the ketamine, so it's less active, so the pyramidal neurons are now active. Now, propofol comes along and says, hey, man, I'll help you out. Here, let's fight that off. So it acts prosynaptically and shuts the pyramidal neurons down. So they're both fighting for the ability of the interneuron to act, and that's exactly what you see here. When you give the propofol, right, for a period, it actually generates just a slow oscillation. You lose the 30 hertz oscillation. When it wears off, it comes back, and that's what happened each of these times I gave him a propofol bolus. And so you can see it here. So there's an inhibitory interneuron right there. And the key thing is that both of these, both the ketamine and the propofol are affecting the interneuron, so they're changing the ability of the pyramidal neuron to spike. That's the key thing. That's the key statement, all right? And just another illustration of the same idea with dexmedetomidine. So this is a case with a woman, again, another VAC dressing change, just on a dexmedetomidine infusion. And so now here, I give a ketamine bolus, and you see you generate the high frequency oscillations. Give them another ketamine bolus, you do the same thing. So again, mechanistically, you can give the same description. The dex is acting at these various sites, sort of blocking norepinephrine release, so you're hyperpolarizing the cortex and the thalamus. And then when you give the ketamine, again, this pyramidal neuron is being helped out by the ketamine, and it's being inhibited basically by the dexmedetomidine, all right? So I just want to say something about what happens with age, because this is very important. So this is propofol, right? Someone who's about 30 years of age. Here's propofol in someone who's 57. Here's propofol in someone who's 81. And you can see in all the cases, you see the slow oscillations and the alpha oscillations. There's some very systematic changes that are occurring as you see the power is dropping down to the 10 hertz power is dropping down to a lower frequency range, and the slow oscillations are becoming weaker. And this idea of the oscillations losing power as we get older is very, very well known. And in fact, the rate at which you might lose power might be different for different people in the sense that we are physically aged differently, our brains age differently as well. And you can actually see that here. And if you look, so here are the kids. This is someone who's 3 years old, and this is someone who's 14 years old. All right? So you can see you have roughly the same dynamic. But if you generate a naive algorithm to measure depth of anesthesia, and you build it on people in these categories here, then you can see exactly why it wouldn't work on very young people, or it could give you misleading information in people who are older, right? So one of the things that's important to do when taking care of older patients is to change the scale on the monitor. If you rescale the monitors, the view, so you can actually see the alpha oscillations, you can see that that older person had strong alpha oscillations just like the younger person. But they're smaller, so you have to see them on a different scale. And going back to this lady here, so she's 81 years of age. She had a tumor on her chest the size of an American football. It took the surgeons the better part of 6 hours to remove it. And she had an epidural in, and we were running a propofol infusion. And we're able to run the propofol infusion around 50 or so, as opposed to about 100 or 120. Because we're watching her EEG in real time, we're able to wake her up on a dime. So significantly reduce the dose of propofol needed to keep her unconscious, right? And so thinking about what happens to the brain as we get older, I just thought I'd put this in here, you know? I just happen to have a Portuguese version of this slide, you know? I don't know where it came from, you know? So what happens? So we don't have to think about, asking, looking for some deep ideas to what's happening or invoke dementia or Alzheimer's. Just think about a neuron, and that's what I'm doing here. So I'm going to take a neuron, And so these are just sort of the kind of the morphologic changes that you can just anticipate. So what happens? So the dendrites don't have the same dynamics. They don't extend and retract as much as they used to. Then we don't produce as much neurotransmitter. The myelin sheath breaks down as we get older. Our mitochondria don't function as well. And the brain tissue just decreases in volume, essentially. So these are things that just happen with normal aging. I can see this is the most popular slide here. All right. These are things that just happen with normal aging. And we don't have to invoke Alzheimer's or invoke, let's say, dementia. It's just like that 81-year-old woman has 10 to the 10 neurons, and each one of them is 81 years of age. So after time, it's going to be much more difficult for her to process exactly the same information. It makes sense that the amplitude of her signals are going to be weaker. And so this is just showing that here as a function of age. So if you look at the total power in the EEG, it actually peaks somewhere around 6 to 8 years of age and declines after that. And the 81-year-old lady is out here. And then if you look at the very young brains, as I was saying a second ago, in 0 to 3-month-old kids, they only have slow oscillations. Then something magical happens at 4 months of age. This is just an empirical observation that they have the alpha oscillations and the slow oscillations, but these don't move. They aren't dynamic. They don't move until the kids, they don't have this forward and backward movement until the kids are between 11 to 14 months of age. And that's just an empirical finding. And then just to tie this together with what we were saying earlier, so the brain goes through these various developmental stages. And one of the key developmental points is the thalamus sends projections up to the cortex. And once they reach the cortex, there are neurons up there that are called subplate neurons. And what the subplate neurons do is they take the thalamic projections and they point them to where they're going to hook up in the cortex. So these projections come up. The thalamic, the neurons indicate where they should hook up. They're like the subplate neurons indicate where they should hook up. They're like ushers in a movie theater. They tell you where to sit. All right, and then they disappear. All right, and so one of the things that we postulated was that that process hadn't taken effect sufficiently back here at 3 months of age. And so we discussed this with Carla Schatz, who's like one of the world's experts on brain development, and she said this makes perfect sense. And one of the most interesting things about it is that she had no biomarkers of this. The earliest biomarkers that she was aware of is about a year of age, essentially. And so this is something you can see under anesthesia when kids are between 3 to 4 months of age, right? So this is what I've told you, that the anesthetics all produce these slow delta oscillations by Bearnaise principle. The differences in the patterns reflect the differences in the neurophysiologic mechanism that we think through which they're working. And I've shown you how this EEG power changes systematically with age, reflecting sort of normal brain development and possibly aging. And so this is a website which we've just updated, which has like pedagogical material sort of covering the things that I've discussed here in this lecture. So thank you.
So I don't know if you want to ask some questions to Emery, discuss some of his issues. Please be free. So, Emery, I'd like to know your opinion. Do you think that, as you said, there's so much information in EEG? Mm-hmm. Do you think that in the near future, intraoperative EEG monitoring should be a standard monitoring?
I mean, my personal opinion is I think it should be. I think it should be a standard. I think that, you know, we've learned a lot. And, you know, we're trying to share what we've learned, you know, with folks so they can, you know, use the EEG perhaps the way that, at least that I've been using in the operating room. And I think there's still a lot more to learn. I mean, I think but if we have a collective experience where we're sort of sharing our ideas and what we're finding, I think we can come to consensus on, a principled approach. I think certainly for older patients, it makes a huge difference in my ability to dose the drugs, and Marus and I are going to talk about some of that, this afternoon. It's made it possible for me to redesign entirely like my approach to anesthesia. And I think that where we failed before was that we had pattern recognition algorithms, but we couldn't put any science behind them. We couldn't say why whatever it was, number or index or whatever, why it generated what it did. And I think as we start to be able to make more principled statements about how the drugs are working, and we can relate those to the patterns, then I think we should have standards using the EEG to do that.
And so, do you agree that we should move from the numbers to the waves, and teach since the beginning how to read the EEG waves to our residents?
I think so, but I think so it should be taught in the context of neurophysiology, though. I think I wouldn't teach it as pattern recognition. I mean, I would teach it as here's a good postulate as to why we think this oscillation comes about the way it does. Here's how the oscillation changes with age, and here's why. So I think if we do it in the context of neuroscience, it'll be much more informative, and I think it'll be much more robust, so that we can actually then build on it as we learn more things.
Okay. May I ask you who normally use EEG monitoring during your cases? So let's see if in 2 years we'll change the numbers. Much more people in the room doing that. So Christian?
Just a short question, Emery. The concept of inhibition, disinhibition, obviously, is interesting. Why is there a different susceptibility of inhibitory and excitatory neurons towards anesthetic action? Because, I mean, the concept of disinhibition states you inhibit the inhibitory neurons first, while the excitatory neurons still can fire in the presence of generalized exposure to anesthesia. So why is this different susceptibility? Is that known?
Well, I mean, I think it's very straightforward to postulate. I mean, the fact that certain receptor systems are more sensitive than others, I think, is very, very clear. And so you have only to look at the fact that they're GABAergic neurons in the cortex, in the thalamus, and the brainstem. But the ones which are most sensitive are the ones in the cortex, because the effects that you're seeing initially, even though the blood had to go by the brainstem to get up to the cortex, it's the cortical effects that you're actually seeing first.
No, I mean, I don't doubt that. Why is that? Why is there a difference?
Oh, I think in the case of the GABAergic circuits there, no, actually, I think in the case of the cortex, I think it relates to the fact that it is neocortical. I think it is evolutionary. Yeah, I think that's probably what's transpiring, because you need to have your brainstem and lower circuits be more robust. Because if they were the ones that were super sensitive, you'd be dropping dead like flies. Tony?
But are you saying that there's a difference in the GABA receptors in the brainstem and in the neocortex?
No, I'm just saying there's just a difference in the. Let's put it this way. That could answer the question. That could certainly answer the question. But either way, empirically, there's clearly a difference.